Learn efficient pharmacology, Pharmacokinetics Part 5, Distribution, Clinical Scenarios. We have seen some of the important factors affecting distribution of drugs in the previous video. Logically, if any of these factors are affected, drug distribution should also be affected. Let's see an example of two highly lipid-soluble general anesthetics, propofol and thiopental. Let's keep it simple. If a sufficient quantity of a general anesthetic drug enters the brain, a person will lose consciousness. If the concentration of the drug in the brain falls, the individual regains consciousness. Now, how do you think will a single intravenous dose of propofol distribute in the body? Remember, we discussed in the earlier video that when a tissue is highly perfused, the drug will be distributed faster to that tissue than to less perfused tissues. Since the brain is a highly perfused organ, the delivery of drug to the brain will initially be much greater compared to other tissues like muscle. But doesn't the brain capillaries have tight intercellular junctions and no fenestrations? Yes, but this will not affect the drug since it is highly lipid soluble and can easily cross the lipid bilayer of the endothelial cell. And as the concentration of the drug in the brain increases, the individual becomes unconscious. Thus, because the brain is highly perfused and the drug is highly lipid soluble, the individual loses consciousness within seconds after drug administration. Now, although the rate of perfusion to muscles is relatively less, over the next few minutes, muscle also receives the drug. The plasma drug concentration falls, and this causes the drug in the brain to move back into plasma. So, as muscle uptake of the drug increases, concentration of the drug in the brain falls, and the individual regains consciousness. So here, a drug that was initially distributed into the brain is subsequently distributed into the muscle. That is, the drug was redistributed. This redistribution we saw occurs within a few minutes. This is why the action of propofol is terminated within minutes. Drug metabolism or excretion has practically no role here. This is applicable not just for propofol or thiopental, but for any highly lipid-soluble intravenous drug targeting the brain. Here, the primary mechanism for rapid termination of effect after a single dose is redistribution. But remember, these drugs are highly lipid-soluble. So, won't these accumulate in adipose tissue? Of course, yes. But also remember that since fat is a poorly perfused tissue, the distribution of drug into fat will not be as fast as it was to the brain or the muscle. Also, redistribution into fat will not be as much as into the muscle. So, in the termination of action after a single dose, it is the redistribution into muscle and not fat that plays a major role. But with repeated doses or prolonged infusions, fat becomes a major reservoir of the drug. In such a situation, to terminate the action of drug in the brain, redistribution into fat or muscle is no longer the primary option because the concentration of drug in these tissues are already high. Here, the drug has to be removed from the plasma by metabolism or excretion so that molecules can move out of the brain. Here is where propofol has an advantage over thiopental. The metabolism of propofol is faster than thiopental, and therefore plasma propofol levels fall faster once the drug administration is stopped. So, the movement of the drug out of the brain is also quicker with propofol than with thiopental. Thus, after repeated doses or prolonged infusion, patients on propofol regain consciousness faster. This example highlights the role of factors affecting distribution in clinical practice. We have provided a few more relevant examples here. Pause the video to view these. Here are some good to know facts. We shall discuss elimination in the next video.